morning from Miami Beach, home of Neurosurgical TV. We have the honor of having Abatha Shah in the second in a series of Roton-like webinars. Today, she's going to be talking about white fiber connection central core. Uh, and I'd also like to introduce Mohammed first. Hello, Mohammed.
Yeah, hi, John. It's here. So,
Yeah, Mohammed's head. Can you tell us about your organization, Mohammed?
yeah. Basically, white fiber core is very important. What we feel, the sulci and gyri are very important. The prefrontal, premotor cortex or motor cortex, sensory cortex, these are of course important. But our feeling is this is much more eloquent than white fiber. When we work around the white fiber, we feel this is not so important like gyri. But we know that in white fiber, that is in the internal capsule, the 1 millimeter in internal capsule is more eloquent than 5 to 10 millimeter in the precentral gyrus. So I think white fiber is much more important than anything. We are going to have the white fiber dissection from one of the big faculty in this world is working on white fiber. It's a very good lecture she has. So we are going to hear from Abida Shah. Thank you, Abida. You are welcome.
Thank you, Mohammed. Thank you, Mohammed. So as you rightly said, along with the cortex, the white fibers are also very important. And let's discuss that today. Before I start my presentation, I'm going to show you a short video. This is the most detailed scan that has been made of the human brain. It is made on a 7 Tesla MRI, and you will see how detailed it is and how white fibers are so important. You will realize from the density.
Can everybody see the video? I cannot see.
No, sir, the video is not available yet.
Yeah.
It's not
No
playing?
video.
No, we're not.
playing.
No, we're not seeing it. Could you
No,
try it
ma'am,
again?
only
Try it
sound.
again, Abby.
We
Try it
can
again.
hear the sound. We can hear the sound, but we cannot see the video.
Okay, I'm going to stop share and do it again, okay?
Yeah, try it again.
Can you see it now?
Yeah,
Yes.
yeah.
Okay.
So that is how detailed our human brain is mixed with the fibers. And now let's begin with our topic for today. Can you see my screen?
Yes.
Okay. So we're going to discuss the central core today. While discussing the central core, we will discuss all the white fibers that come in the way while approaching the central core. So this is a recent publication that we have made, and this is the list of damage to all the white fibers that can occur. when you're operating on the brain. So this was the paper. What we have done is we've classified white fibers of the brain into these 5 groups. So you have the superficial group, which is the short association fibers or the arcuate fibers. The middle group, that is mainly the long association fibers, where you have the SLF, the arcuate, the inferior longitudinal fasciculus, the middle longitudinal fasciculus, the uncinate, the inferior fronto-occipital fasciculus, and the sagittal stratum. This deep group are the fascicles that are in relation with the ventricle and in and around the corpus callosum. They are mainly all C-shaped. So you have fornix, you have stria terminalis, you have stria medullaris thalami, and the medial and lateral longitudinal striae. Right in the center of the brain is the central group, and this is made up of all the commissural fibers. So you have the corpus callosum, the anterior and posterior commissure, the habenular commissure, and the hippocampal commissure. And dividing all these groups, mainly the middle group, right in the middle of each hemisphere, is the vertical layer or the projection fibers, which are the internal capsule and the thalamic radiations. So this is the classification. You can see this yellow circle here are the short association fibers, which are connecting your neighboring gyri. This purple circle here are the long association fibers or the middle group. The red circle is the one that is the deep group in relation to the ventricle. The green circle is the commissural fibers, and the orange vertical circle here is that of the vertical fibers, here which is being depicted as the corona radiata. So what you saw in the scans, these are if you see in a DTI image, these are the fibers that connect neighboring gyri to each other. This is the first layer, that is the superficial group. Then you have the long association fibers or the middle group. So what happens here? Which you see this blue structure here, which is running right from superior to inferior, is the corticospinal tract. What this vertical fiber group does is divides the middle group on 2 parts. In one part that is in the lateral aspect of the hemisphere, and one part that is in the medial aspect of the hemisphere. So when you see on a diffusion tractography, these are the fibers that you will see on the lateral aspect. So you have the IFOF, you have the ILF, you have the arcuate fasciculus, you have the optic radiations. And when you see medial to the corticospinal tract, you will have the SLF medial part, the cingulum, and when you look at it, all the commissural fibers. So when you see from superior, you see this vertical projection fibers right in the middle, bifurcating, dividing the hemisphere into medial and lateral, and all the commissural fibers remain between the 2 vertical group of fibers on each side. So you have the corpus callosum here, the biggest commissure, the posterior commissure, the habenular commissure, and the hippocampal commissure. All are between this. The only fiber, the only commissural fiber that will cross across and go to the other side is the anterior commissure, as it goes on to join the sagittal stratum, as we will see later. So this anterior commissure also forms part of the central core, and the anterior commissure is the commissural portion of the central core. So now let's get into the topic of today after this introduction. What is the central core? Basically, it is made up of the insula, it is made up of the lentiform nucleus, it is made up of the caudate nucleus and the thalamus with the internal capsule between these structures. So if you realize, this central core is straddled between the internal capsule. So you have the lentiform nucleus, which is medially, and you have the thalamus and the caudate nucleus, which is laterally. And surrounding all of them, like an external shield, is the insula. So on the lateral aspect, the insula forms a shield and covers the central core. And on the medial aspect, the ventricular surface forms a shield and covers the medial aspect of the central core. So this is how it is contained inside the most inner aspect of the brain. We will see how this central core connects to the cerebral hemispheres as we progress in the lecture. So if you see from this is anterior, this is posterior. So this is a little lateral and superior view of the hemisphere. This is the region of your central core. This is your corona radiata with the internal capsule going down. These are the fibers that are running on top of the central core on the lateral side, behind the central core on the lateral side. And we will see one by one each of them. So this is from the lateral aspect on the lateral part of the projection fibers. And when you see from the medial aspect, you have the cingulum here, you have the corpus callosum here, and you have the region of the caudate and the thalamus here. So this is on this side of the internal capsule. And these are the fibers that you will traverse when you're approaching it from the medial side. So this is an over the top view. Here you can see the entire corona radiata, which is merging down into the internal capsule. These are fibers of the SLF lateral to the internal capsule. These are fibers of the SLF medial to the internal capsule. This is the corpus callosum. This is the arcuate here below. And between this, laterally and medially, are your deep grain nuclei that form the central core. Now, how do we start studying this? So when you want to approach the central core, you have to either do it from a lateral aspect or you have to do it from a medial aspect. So let's start from the lateral aspect, where we will dissect one fiber layer by layer to see how we reach the insula and then the central part of the cerebrum. So this is the lateral view of the hemisphere. I think everyone is familiar with all the sulci and gyri here. This is the Sylvian fissure region. Now, when you remove all the arachnoid and all the vessels, this is what you will see, the majestic view of the cerebral hemisphere from the lateral aspect. So here you have the pars orbitalis, you have the pars triangularis, the pars opercularis. This region here is the anterior Sylvian point, which is used mainly to approach tumors of the insula or to open the Sylvian cistern. This is the region of your subcentral gyrus, that is the connection between the pre and post-central gyrus. This is your supramarginal gyrus here, and this is your superior temporal gyrus. So the insula, the hidden island of Rale, is covered by the frontal, temporal, and the frontal, parietal, and temporal opercula. As I discussed before, it is pars orbitalis, pars triangularis, pars opercularis, the subcentral gyrus, parts of the supramarginal gyrus, and mainly the temporal polar region of the superior temporal gyrus, the planum polare. So this is the operculum. The operculum, the name signifies, operculum means a curtain. So when you draw the curtain, you will be able to see the insula. So this is from the superior aspect, just to orient you when I start the dissection. So this is the superior aspect of the cerebral hemisphere. You can see the central sulcus here with the precentral gyri and the superior and the middle frontal gyrus. So now we start dissecting here. So once your specimen is prepared, you start removing the superficial gray matter on the surface of the surface of the hemisphere. And this is what you will see. You will see this white line here in between, surrounded by gray matter. So this is your short arcuate fibers. These are your short arcuate fibers that are running all across in the hemisphere, and they're surrounded by this gray matter. So when you remove it, here the gray matter on top of the little bit on the cortex is being maintained, but in the depths of the gyri and the sulci, the gray matter has been removed, and you start seeing the short arcuate fibers and their various connections to each other. There are innumerable connections between each of these short gyri, and that is what helps in brain plasticity. So this is from the lateral aspect, when you see that all the gray matter has been removed, and you can see the connections between all the gyri. So you can see this one connection that is between the middle frontal gyrus that is connecting to the precentral gyrus in this region. There is another connection from the superior frontal gyrus to the precentral gyrus here. Then you can see how the inferior frontal gyrus communicates in this area with the precentral gyrus, and how each gyri of the inferior frontal gyrus communicate with each other, how the middle frontal gyrus communicates with the inferior frontal gyrus. So there are innumerable short arcuate connections that we tend to ignore when we are operating, but it's good to realize that we are damaging some connections when we are operating like this. So what happens when you start removing fibers on the lateral aspect? So the first fiber that you will see here running from the frontal pole, so middle frontal gyrus and inferior frontal gyrus, all the way to the supramarginal gyrus here, is the superior longitudinal fasciculus. Traditionally, this has been called as the SLF part 2 or the SLF part 3. It is very difficult to distinguish between SLF2 and SLF3 in this region, and most of them run together. Only thing is you can make out is there is a difference in gradient. Maybe this is higher and this is lower when you're seeing the specimen, but otherwise you cannot differentiate. So SLF2 and SLF3 are lateral to the corona radiata and the internal capsule, and I like to call it the lateral SLF. The medial part of the SLF is medial to this, and we will see it later. This fiber bundle that you see here is a short arcuate fiber connection between Broca's area, which was present here, to the arcuate fasciculus, which you can see the connection here is connecting to the arcuate fasciculus, which is going all around in the region of the supramarginal gyrus, then turning inferiorly here and ending here in the region of the superior temporal gyrus. So the opercula have been removed here, and you start seeing the region of the insula. And these are the fibers that come in this region when you are after removing the opercula. These are fibers of the corona radiata. Some gray matter is still present here, which we have removed now. So now you can see only the white fibers. Now you can very clearly see this fiber bundle that is running from the middle and inferior frontal gyrus. This is the middle, this is the inferior, and here is the SLF2 and 3 or the lateral SLF. This fiber that is seeing as a C-shaped structure is the arcuate fasciculus. It surrounds the insula completely, and these are fibers of the corona radiata. So when you're approaching the insula, when you go from the region of the operculum, either the frontal or the temporal operculum, on the dominant side, this is the area that you have to be careful that you don't damage the arcuate fasciculus. Now all the gray matter has been removed, and you can see the fibers more clearly. The gray matter of the insula also has been removed. We will go into the insula shortly, but this is the structure that you've seen here is the extreme capsule. So this is the SLF2 and 3. This is the arcuate fasciculus. This bundle that is running from the temporal to the occipital region is the ventral occipital fasciculus. These are fibers of the corona radiata. So when you come from the lateral aspect, when you're approaching the region of the insula, these are the fibers that you have to be wary of. Once you are aware of these fibers, once you've safeguarded them, you can enter the insula. So this is a depiction of the white fibers on the lateral aspect of the cerebral hemisphere. So now let's start with the central core area. So this is the curtain that is covering the insula. This is the Sylvian fissure. Now what happens when you open the curtain? This is the magnificent hidden island of Rayleigh or the insula. Now the insula has its own gyri, has its own white matter. So let's look into it one by one. Now, if you realize the insula has two surfaces, this is the anterior surface of the insula here, and this is the lateral surface of the insula. The anterior surface of the insula is covered by mainly pars orbitalis of the inferior frontal gyrus, and the lateral portion of the insula is covered by the rest of the operculum. Now the gyri of the insula are actually divided mainly into anterior and posterior gyri by this sulcus here. This is the central sulcus, again central sulcus. And if you see the direction of this central sulcus, it follows and continues in the same direction as the central sulcus of the brain. So it's in the same direction. If you see it closely here, this is the central sulcus, this is the subcentral gyrus, and this is your central sulcus of the insula. There is another pre-central insular sulcus and a post-central insular sulcus that divide the insular gyri. Now this region here of the insula is the Lyman insulae. Now what is Lyman insulae? Lyman insulae is the connection that occurs between the insula and the base of the frontal brain, where you have the substantia innominata, where you have the lateral olfactory striae. So basically this Lyman insulae goes laterally and connects with the lateral olfactory striae. When we see from inferior, I will show you the connection. Now this gyri here, this is the transverse gyrus of the insula. This is the accessory gyrus of the insula. These are the anterior gyri, anterior, middle, and posterior short gyri. And this is the anterior and posterior long gyri. Generally, this long gyrus here may be single and then divided here into two parts. It is a little inconsistent, but these are generally very, very consistent. Now, how do you differentiate between the anterior gyri and the posterior gyri? If you look here closely, you will see here this anterior gyri along with the transverse and the accessory gyri originate from a single region. This is the region of the insular apex. They start here and then radiate all around. Whereas you see if the posterior gyri are separately seen from the anterior gyri.
Excuse me,
So
Abby. Abby,
yeah.
should I interrupt you if someone has a question, or do you want to just finish and questions after?
You can interrupt if you want.
Okay. Nasser, do you have a question? Nasser Udin, you had a remark. I wanted to make sure it was okay with Abby first. Go ahead. Now that you have something to say, Nasser Udin. Well, false alarm, Abby. Sorry.
I think maybe we'll do it at the end only. I think it'll be better, right?
Okay. Okay. Yeah.
Yeah. So these are the gyri of the insula. This is, and as you see, the insula is a pyramidal structure. It has an apex and it has a base. And surrounding all around the insula is the circular sulcus of the insula. As you see here, this again circular sulcus of Rayleigh, that's what's called. It is divided into three parts. So you have the anterior limiting sulcus, you have the superior limiting sulcus, and the inferior limiting sulcus. So the point where the anterior and the superior limiting sulcus meet here in this region is the anterior insular point. And the point where the superior and the inferior limiting sulcus meet is the posterior insular point. So this is the gray area of the insula, and this is the limiting sulcus. Now, what is this region of limiting sulcus is where the insula connects with the cerebral hemispheres. So if you see closely as we go ahead, you will see that the insula connects with the cerebral hemisphere by the external capsule, by the internal capsule, and by the extreme capsule. Let's see all these connections. So when you start removing the short gyri and the long gyri and all the gray matter of the insula, this is the first layer that you will see, and this is the layer of the extreme capsule. So these are your limiting sulci, and this layer here is the extreme capsule. What is the extreme capsule? The extreme capsule connects neighboring insular gyri. As you can see here, it connects these insular gyri to each other, and it connects the claustrum to the cortex. So the layer beneath this will be the claustrum. It is a claustrocortical system which connects the gray matter of the claustrum to the cerebral hemisphere and connects the insular gyri to each other. When you remove this layer here, when you start removing the extreme capsule, you start seeing some gray matter in this region. It is very thin and it is difficult to preserve sometimes. This is the region of the claustrum. So once you remove this entire extreme capsule, you will start seeing the gray matter of the claustrum. After the claustrum comes the external capsule. Now these fibers that you see here are the external capsule. This gray matter that is beneath the external capsule is the putamen, and beneath the putamen is the internal capsule. The external capsule is actually made up of two parts. We have the dorsal external capsule and the ventral external capsule. So this portion here is the dorsal external capsule. As you can see here, it is going along the limiting sulcus and going just beneath it to join the cerebral hemisphere. This is the ventral external capsule, and it consists of two parts. You have the IFOF here and you have the uncinate fasciculus. So you have the ventral external capsule and the dorsal external capsule. This is a very typical appearance that you see when you remove fibers of the external capsule intermingled with the putamen. It's a typical spoke and wheel appearance that you see of the external capsule. So this is another image where you can see the ventral part of the external capsule. This is the IFOF running into the temporal region. This is the uncinate, which is running from the frontal to the temporal region. And this is the region where both of them come across very close to each other. And this is the dorsal external capsule. as it is covering the lateral aspect of the putamen. When you remove it, when you remove the entire external capsule, when you remove the putamen, you start seeing the globus pallidus. And this is basically a little basal to the putamen. It just lies posterior to the anterior commissure that you will see here. And this is the fibers of the internal capsule. So this is another image where all the central gray matter, central core on the lateral aspect of the internal capsule has been removed. And this is the entire extent of the internal capsule. So when you go from laterally, this is where it will end. The central core ends here. Then there is an internal capsule, and then you have to go on the medial aspect. You cannot cut the internal capsule and go on the other side. What will come after the internal capsule are the thalamic radiation, and then you will come across the thalamus and the caudate nucleus, which we will see from the medial aspect. So this is the entire internal capsule. Here you can see the anterior limb, the genu, the posterior limb, the retrolenticular portion, and the sublenticular portion. That is classically the Mayer's loop. This small connection that is left is that of the IFOF, as it is going to connect as a layer in front of the anterior commissure. And this bundle that you see here, this is your region of the globus pallidus. Once you remove that, this is the bundle that you will see is that of the anterior commissure. So all these fibers, the IFOF, the anterior commissure, and the optic radiation, they form a series of layers here, which is called the sagittal stratum. I will show you in a better image how it looks. So let's again have an overview of the central core from the lateral aspect. So when you remove the fibers on the lateral aspect of the hemisphere, you have the SLF 2 and 3, you have the arcuate fasciculus, you have the corona radiata. And then when you go inside, you have the putamen. These are the fibers of the dorsal external capsule, and these are your fibers of the ventral external capsule. So you have the IFOF and you have the uncinate, as you can see here, going from frontal to temporal. This is the region where the putamen and the gray matter of the central core, that is the lentiform nucleus, has been removed, and you can see the beginning of the internal capsule here. So basically I told you the external capsule goes above just beneath the limiting sulcus and goes up, and the internal capsule similarly also goes up, and together in this region they form the centrum semiovale, or the corona region of the corona radiata. So these corona radiata is the fibers of both the external and the internal capsule as they go up and connect the central core to the cerebral hemisphere. And this region here is the region of the sagittal stratum. So you can see here, these are the fibers of the IFOF, that is the first layer that is coming here. Then you have some fibers of the anterior commissure as they're going here. And then these are the fibers of the optic radiation that is going all the way to the occipital pole. So this complete region here is the region of the sagittal stratum. It is called stratum. Stratum means a series of layers, and it is called sagittal stratum because it is consisting of 3 layers. So just to look at the IFOF more in a better way, this is your IFOF that is coming from where does the IFOF start in the frontal lobe? It starts from the middle and the inferior frontal gyri and the lateral orbital gyri. So it joins from there, comes here in front, right in the base of the insula. So in front of this is the region of the Lyman insulae, and deep to this, these are your fibers that you'll get here. This is your sagittal stratum, and this is the cut part of the uncinate fasciculus. Now, how are these fibers related to the temporal horn of the ventricle? That is what is important for us to know. So this is your IFOF. The specimen has been tilted a little bit. You can see how the IFOF is going here to form the sagittal stratum. And when you tilt it a little more, you start seeing the temporal horn and the hippocampus in the temporal horn. So you have the head, body, and the tail of the hippocampus. And as you can see here, these fibers, they are coming here and going here. So it forms the roof of the temporal horn in the anterior aspect. And as you go posteriorly, it also forms a component of the lateral wall of the temporal horn. And this is your region where is devoid of any fibers. So it is safe to enter the temporal horn in this region. And this is the entire lateral aspect with all the gray matter removed. And you can see the internal capsule superiorly as it goes to form the corona radiata here. and inferiorly as it goes on to join the cerebral peduncle. This is the hippocampus that has been deflected here. You can see this would be the region of the temporal horn, and this is the roof, and this is the lateral part where the temporal horn is covered. So the central core, as I said, is connected to the cerebral hemisphere by 3 isthmi. So that they are the extreme capsule, the external capsule, and the internal capsule. So the extreme capsule connects superiorly and is the crosstrocortical system. And the external and the internal capsule, they connect to the cerebral hemisphere by means of the corona radiata. And also it connects to the temporal and occipital region by forms of the retrolenticular and the sublenticular form of the internal capsule, that is the auditory and the optic radiation. So this is an insula and its relation to the ventricle. So you have this region, the anterior part of the insula and the posterior part of the insula. So the anterior part here, if you go deep here, it connects between this and the frontal horn of the ventricle. There is only a very thin layer of the anterior limb of the internal capsule in this region. And in the depth, this region is directly related to the caudate nucleus. In this region here, it is directly correlated and related to the thalamus on the middle aspect, but it has a thick bundle of internal capsule fibers in between. These are the fibers of the corticospinal tract and the corticonuclear tract, which form the genu and the posterior limb of the internal capsule. And just posteriorly, at the posterior insular point, you have the insula related to the pulvinar of the thalamus, which forms a part of the atrium. Another thing to note is the central core. It communicates with the brain via 3 subarachnoid spaces. So laterally, it will communicate with the Sylvian system. As we have seen, we entered it from the Sylvian system. Medially, it communicates with the ventricle, the lateral ventricle. And inferiorly, the base of the central core is where it communicates through the ambient and the quadrigeminal cisterns, ambient, crural, and the quadrigeminal cisterns. And this demarcation is where the optic tract surrounds the midbrain. So that is your base of the central core. It basically connects in the region of the subiculum and between the subiculum and the thalamus superiorly and the subiculum medially. Just beneath is where you can communicate with the ambient system. So what we've done is we've done the dissection of the central core from the lateral aspect. Now we have to look at it from the medial aspect. So this is the medial aspect of the hemisphere. Now in this specimen, the cut has been made a bit more towards the other cerebral hemisphere to see the central core structures. So you have the caudate nucleus here, you have the thalamus. So basically the caudate nucleus wraps around the thalamus. So you have the caudate nucleus and you have the thalamus here, and you have some fibers of the internal capsule. When you remove this, you start seeing the corpus callosum, and we are all familiar with the parts of the corpus callosum, the rostrum, the genu, the body, the splenium. This is the ependyma of the lateral ventricle. This is the region of the thalamus here, and this is, of course, the brainstem. So when we remove this ependymal layer, this is the central core structure from the medial side. So this structure that you see here is the head of the caudate, which is continuing as the body, and then it turns around and ends in the roof of the temporal horn. So between the caudate and the thalamus here, there is another fiber tract that runs. If you can see it here, it's not very clear, but this is what it is. It is the striae terminalis. The striae terminalis connects the amygdala to the bed nucleus of the striae terminalis, and it is actually the dorsal amygdalofugal pathway. It is a part of both the limbic system and also a part of the central core. So from the medial aspect, you have basically 2 structures, the caudate and the thalamus, and we'll see what happens when you go further. And this is the other fibers that come in way when you're looking from the medial aspect. So as I told you, this structure here that you can see above here is the medial part of the SLF, or traditionally called as the SLF1. And this fiber bundle just beneath it, going all the way from below the corpus callosum and all the way around to the temporal area again, is the cingulum. So if you see from the medial aspect, you have a series of C-shaped structures. You have the cingulum, you have the corpus callosum, you have the caudate which turns in a C, you have the fornix which turns in a C, you have the striate terminalis which turns in a C. So all these C structures are also a big component of the limbic system, as we will see in the next lecture. So when you start going from the medially, I've removed half of the corpus callosum here, and now you can see the caudate head very nicely. Some part of the thalamic gray matter has been removed, and you see the mammillothalamic tract. Again, this is a component of the central core that connects the mammillary body to the thalamus. And once you remove the caudate head, okay, before I go that, this is the cingulum here. The cingulum also has connections to the cortex, and it ends here in the entorhinal area as the radiation of the cingulum. This region between the fornix and the thalamus is your choroidal fissure. And again, that is a C-shaped structure that runs all around the fornix and the thalamus. So now we remove the head of the caudate nucleus, and this is what you'll see. These are your thalamic radiations. So now we have reached the medial aspect of the projection fibers. So you have the internal capsule laterally, you have the thalamic radiation medially, you have the caudate and the thalamus on the medial aspect, and you have the lenticular nucleus on the lateral aspect. So basically, these are your main components of the central core. And the central core is connected to the cerebral hemispheres, again, as by the external, extreme, and the internal capsule. So again, this is another image where you can see here, this is the region of the hippocampus. This is the temporal horn. This is the amygdala. This is where the amygdala connects with the globus pallidus in this region. There is another region here, which is also considered a part of the central core, and it is called as the ventral striatum. So corpus striatum is basically a part of the caudate along with the globus pallidus together is called the striatum. Corpus, that is the dorsal striatum. You have another small area at the base of the brain, at the base of the frontal brain, that is the ventral striatum. So this is your medial aspect. This is again the cingulum. This is the SLF1 or the medial SLF. So now let's look at the core portion of the central core that is in the inferior aspect of the hemisphere. So this is, okay, again, as I told you, where the central core communicates into the ambient system, this is the region here. This is where the optic surrounds the midbrain and joins the lateral geniculate body in this region. That is your demarcation, where the base, that is considered to be the base of the central core. So this is the frontal, inferior aspect of the frontal brain. You have the H-shaped cruciform sulcus of Rolando. You have the gyrus rectus with the olfactory sulcus. And these are the medial, anterior, posterior, and lateral orbital gyri. A closer look at the base of the brain, and this is your region that we are talking about. This is your region of the ventral striatum. So as you see here, this is the well-known anterior perforated substance. This is where the cerebral peduncle is, the internal capsule is becoming the cerebral peduncle in this region. This is your region. If you see on this side, you will see as the uncus. And here, if you see, this is the region of the amygdala. So this portion here, if I told you in the beginning of the lecture, if you remember, that I said the Lyman insula connects to this region of the lateral olfactory striae, and it connects just beneath here the anterior perforated substance. And this region that consists of the nucleus accumbens, also known as the substantia innominata, is your ventral striatum. So you can see it very beautifully in this image here. You can see this gray matter mass here. This is the nucleus accumbens and the substantia innominata. What you see here, the posterior border of the anterior perforated substance is your anterior commissure, which is again the commissural fiber of the central core. And this is your communication. If you can imagine, this is the inferior aspect. If you turn it, this is your region of the Lyman insulae. This is where the Lyman insulae portion, where the connects with the ventral striatum. And also you have many fibers of the amygdala. If you see here, this is the region of the amygdala nucleus. These fibers have been removed here, but they connect all the way to this region. And this portion is your ventral amygdalofugal pathway. It actually consists of a diagonal band of Broca and the ansa peduncularis. We don't see it in this image, I will see if I can get you an image next time. So the anterior commissure has two components. It has a frontal component and it has a temporal component. Now the temporal component, as we saw previously, it forms part of the sagittal stratum. So this is your eye foff here. This is your anterior commissure, and these are your optic radiation loops as they are turning and forming the sagittal stratum in this area. And you can see here, this is the thin layer of the anterior limb of, this is the internal capsule, and this is the anterior limb of the internal capsule that separates the caudate from the medial side. So this is again a closer view that is showing the anterior limb of the internal capsule. This is your anterior commissure. This is your internal capsule becoming the cerebral peduncle. And now if you see the component of the anterior commissure, basically the anterior commissure hugs the temporal lobe. If you imagine it bilaterally, this is your anterior commissure. It is becoming here, as it is coming here, going laterally, it fans out into the sagittal stratum. And here it goes all around the temporal horn bilaterally. And so kind of hugs the temporal lobe on both the sides. And this is your region of the ventral pallidum, ventral striatum, that is the nucleus accumbens and the substantia innominata. This is the region where the cerebral peduncle is formed. So in the depth in this region, you have the internal capsule. And this is an image where you can see the anterior commissure very beautifully, as it is, this is the temporal line extension of the anterior commissure as it joins and forms part of the sagittal stratum here. And this is a DTI image showing the anterior commissure. So that ends part one of this lecture, where you can see the entire anatomy of the central core. Now the question arises is, why are we studying this? Why are we studying this anatomy? Why is it important? So basically earlier there was a theory of only cortical areas being eloquent. You had the classical Broca's area, you had the classical Wernicke's area. But it is now that we are in this area where we consider everything as a connectome. So you have both the cortex and the subcortical matter that is important and essential for function. This is a very complex diagram. This was the initial appreciation of classical Broca's and Wernicke's area. And this is how we now look at, this is a language map. This is how we now look at how language is projected in the brain. So briefly, I will just show you the pathways. So this is the semantic or the ventral pathway. The basic ingredient of this pathway is the IFOF, and the other cortical portions are the superior and middle temporal gyri, the dorsolateral prefrontal cortex, and the inferior frontal gyrus. If you damage this in the dominant lobe, you will have semantic paraphasias, and non-dominant, you have non-verbal comprehension disorders. So as you can see here, the superior and middle temporal gyrus, the IFOF I will show you. This is the region of the dorsolateral prefrontal cortex and the inferior frontal gyrus. And this is your IFOF. So when you're operating on tumors in the insula, if you damage this fiber tract in this region, in the region of the Lyman insulae, that's when you're going to have a problem with semantic paraphasias. This is the first speech pathway and the second speech pathway. Basically, there are two, a ventral pathway and a dorsal pathway. So the dorsal pathway is the phonologic pathway, and the components are the inferior and middle frontal gyrus, the superior temporal gyrus, and the main constituent is the arcuate fasciculus. So as you have seen here beautifully, the arcuate fasciculus that is just hidden underneath the opercula of the covering the insula. So this is your phonologic pathway, and this is both the pathways here. So you have a dorsal pathway and a ventral pathway, and if there is damage in this area, you will have phenomic aphasia. So what other things that are important in this region when you're operating is the spatial awareness, which is mainly coordinated by the lateral part of the SLF and the superior temporal gyrus and the supramarginal gyrus. So you have the SLF 2 and 3. This is the region of your supramarginal gyrus. This is the region of your superior temporal gyrus. Now the region of the insula and the internal capsule. So you have the main motor and somatosensory function that is coordinated by these areas. So you have the pre and post central gyri, the corticospinal tracts, and the medial thalamocortical fibers. So this is your central sulcus, the pre and the post central gyri, and this is your region of the internal capsule. In another specimen, anterior limb, genu, posterior limb, and the sub and retrolenticular portion of the internal capsule. Now the insula. where is the major the insula and the basal ganglia and the white matter connections have a big role in motor and language control and execution and planning. So the constituents are the supplementary motor area, pre-supplementary motor area, dorsolateral premotor cortex, the insula, and the region of the basal ganglia. So all these areas, dorsolateral prefrontal cortex, the motor and the sensory areas, and the region of the insula, supplementary motor area as it comes in the middle aspect, and this is your white fiber connections in this region that are important for motor planning. And lastly, what is naming? So naming is carried out mainly at this junction, temporoparieto-occipital junction. If you see this junction, there is a myriad of fibers that come here and they meet each other. And if you damage that area, you're going to have a serious problem. So what are the constituents? The middle and posterior parts of the superior and middle temporal gyrus, the superior inferior parietal lobule, angular gyrus, and the connection is the SLF3. So this is the region here where a lot of fiber tracts come into play. And if you can see here and appreciate it, this is the arcuate fasciculus, which will come here. This is the lateral part of the SLF, 2 and 3, which will also come here. You will have fibers of the IFOF, you have fibers of the anterior commissure, and you have fibers of the optic radiation. All these, this whole junction is your parieto-temporal occipital junction, where there is a host of fibers which can cause a problem if you damage them here. So just a few clinical cases. So this is a region, this is a tumor in the region of the Broca's area. We did a functional and we do a tractography and a DTI planning in all the patients. So basically DTI is a tool. Okay, it is helpful to you, but it is helpful once you know the anatomy. Basically, when you're planning any tumor, it is better that you go and perform your tractography. And you can perform the tractography only if you know where the fibers are. If you know that I have to draw in this region the arcuate fasciculus, then your machine will pick it up. So this is your tumor in this region here. This is the relevant anatomical image. This is where the tumor is. And you can see here in this tractography image that the arcuate fasciculus is displaced medially and the SLF2 and 3 are displaced superiorly. And you can safely enter this tumor here. Only problem is because it is so closely related to the functional area, this was performed awake, and you can see here small part of the tumor has been left behind to preserve speech because the patient had some problem during surgery. This is another perisylvian tumor where you can see the relevant anatomy here. If you just without the tractography, if you know that your arcuate fasciculus is here, your IFOF and your uncinate fasciculus are pushed downwards and medially. If you know your SLF2 and 3 are pushed superiorly, I don't even need a tractography. But of course, tractography is important. You go in and enter this tumor and you can remove it very radically without any problem, without any monitoring, without anything. This is again another peri-insular tumor in this region. And you can see the tractography here. This is the tumor. As you can see that some fibers have been pushed superiorly and all the other fibers are medial in this region. So you can very safely enter and remove this tumor. As you can see in this post-operative image, some tumor has been left along the MCA. This is now proper insular tumors. So tumors of the central core, basically you have tumors of the insula, you have tumors of the caudate nucleus, which are not that common, but you do see them, and you have tumors of the thalamus. So these are the main components of the central core that get affected by tumors. So this is a typical insular glioma that is involving both the frontal and the temporal region. And the fibers that you have to be wary of are the arcuate fasciculus and the IFOF. So arcuate will come superiorly, your IFOF will come inferiorly. And in the depth, you will have internal capsule. So basically, if you do not cross your external capsule, if you limit yourself to your claustrum, you're not going to cause any damage. So here you can see the post-op image. Here you can see that this is the layer of the lentiform nucleus, which is very beautifully preserved without any problem. What is the second deterrent for insular glioma surgery? And that is that there is a plexus of vessels here. As you can see, this is the Lyman insulae and the MCA bifurcating into the M3 and the M4 portions, but it runs between the short insular gyri. So that is again a major deterrent to the surgery. And it is critically important to preserve all these vessels, otherwise there will be a problem. And these are the lenticular striate arteries, which you can see that are going from the middle aspect of the vessel straight into the lentiform nucleus and supplying there. These arteries are present at the Lyman insulae, where the MCA, where the M1 becomes M2 is classically the Lyman insulae. And that is the region where the medial lateral lenticular striate arteries also come out and supply the lentiform nucleus. So this is a short technical thing I had reported. For operating, if you can use indocyanine green and you can visualize the vessels, you can nicely preserve them. Sometimes when there is some confusion, and you can preserve the MCA in this area. So this was the tumor that I was operating. And here you can see how close the MCA is. This is a short video. I'll just show parts of it. So this is the insular tumor. And you can see here the region, the MCA here that is being seen here. Now what happens is this MCA, there is a branch that goes here, which ends somewhere, which was going around the tumor, and it was not very easy to distinguish where it was going. So if you can see, this is the part of the tumor. This is the branch of the MCA that is turning around the insula, around the tumor here. Now just see if you can see that branch clearly. It's right here. So basically then we used indocyanine green to delineate the course of this vessel, basically to see whether it was a long vessel that was going along and going across, long perforating artery that is going across to supply the part of the cerebral hemisphere. So the ICG helped us in identifying this vessel, and it was safeguarded very nicely. As you can see here, this is the main trunk of the ICA. This is the vessel that is going all the way and then going into the cerebral hemisphere in this region. Here in this region, it was difficult to distinguish whether it was turning here or going superiorly. So that's when the ICG was used. And see, this is the vessel that has been separated from the tumor here. Here you can see it very nicely. This is the MCA. This is the branch that is coming. Here you can see that branch that is being separated. And this was a very firmish and rubbery tumor, as you can see, it being separated. And the vessel and its entire course has been preserved here. And just a small, and also ICG helps if you have some difficulty in identifying the lenticular striate also, arteries also at the Lyman insula. So basically, this is the tumor that has been removed. And this was the post-op scan. As you can see, a very good excision was performed. This is another tumor of the insula, which is quite localized to the insular gyri. And if you understand the anatomy and the tracts in the vicinity and your boundaries as to what you do not go beyond, then you will be able to perform a radical resection. This is another tumor of the insula, more in the temporal region, closely related to the MCA. This is the DTI, and this is the post-op image. Now, this is a tumor that is going all the way of the insula and also going up to the caudate nucleus here, you can see. So again, it's important to understand the anatomy of this region, the anatomy of all the fibers that come in this region, and how you can approach this tumor by making a small cortical incision in the area. This is the fiber tracts. You can see the internal capsule here. The arcuate fasciculus has been displaced laterally, and you enter the tumor, and this is the resection. As you can see, even this component of the tumor was removed, as you can see in this image. So another approach that we described was an orbital cortical approach to lesions in the lateral aspect of the frontal horn. So basically the caudate nucleus. So this is a tumor where you can see. So we saw tumors of the insula. This is another rare variety of the tumor that is of the caudate nucleus, typical location in the lateral aspect of the frontal horn. And we approach this tumor by a lateral, making a small incision in the middle orbital gyrus, and then directing the incision, lateral orbital gyrus, and directing it towards the caudate nucleus. And you can see the excision here. A very good radical excision was obtained. There's another caudate nucleus tumor where you can see its relation, typical location of the caudate nucleus. And again, a lateral orbital incision was made and the tumor has been removed, as you can see. So that ends my lecture. Thank you very much.
Okay, great, Abby. Okay, Mohammed, do you want to lead the discussion?
Yeah. Thank you, Professor. Excellent presentation. It's a very deep live streaming I was just looking at the presentation. I was actually white fiber dissection. I was inside the white fiber. The lecture was so vivid. Thank you very much. And we have learned a lot actually. The participants here, we know it has already crossed 150, and many of our participants couldn't enter through the Zoom. They had to enter through the YouTube. So sorry for this interruption. So thank you for presentation. I would like to request Professor Hugo Perez, sir, to put your valuable comments regarding this beautiful lecture.
I was going to suggest that, Mohammed. You're one step ahead of me.
Ah.
Go ahead, Victor. Hey, Victor, you're here, right?
Hello, how are you?
Hello.
Nice
Hello.
to see you. Hello. Excellent lecture. Very useful for young brain surgeons and also for experts. Really nice. A complete description of white fibers. Congratulations.
Thank you, Dr. Victor.
Abhida, can I ask a question to you?
Yeah,
Yes.
of course, sir. You can.
Okay. Abhida, what a wonderful lecture, professorial lecture. Abhida, my one question is, tumors and all, they displace all these fiber tracks. So we are not sure where these tracks are in tumorous condition. It's more important for functional procedures like epilepsy surgery. My question to you is, so many approaches have come for amygdalohippocambectomy. Spencer's procedure from middle temporal gyrus. You can come from below through the fusiform gyrus, then Sylvian fissure through inferior limiting sulcus of the insula, or even transchoroidal approach. My question to you is, you have told, one approach people do is through the inferior limiting sulcus, make an incision behind the Lyman insulae, and then go to the temporal horn. My question is, you told three things which will come in the way if you are not careful. One is IFOF, other is uncinate fasciculus, and other is optic Mayer's loop. So how much we can go make an incision in the inferior limiting sulcus behind the Lyman for safely entering temporal horn?
Basically, sir, what we do when we are doing amygdalohippocambectomy is people like this trans-Sylvian approach, but I feel it is dangerous in this because one is of course because of the vessels, and one is because of this IFOF and uncinate, because there is no clear demarcating margin between where you can make the incision and where you may damage it. What you have to do is actually go a little bit superior, superior to your Lyman.
Yeah.
If you go superior to the Lyman in the inferior limiting
okay.
sulcus.
Abhida, your voice is okay. Abhida, my next question, we also know that, if we make an incision in the inferior limiting sulcus, posterior to the Lyman, it can injure all these tracks, which obviously one wants to avoid. So what many people do, one structure which is just below or just in front of Lyman is amygdala. So that is how trans-amygdalar approach has come to the temporal horn. They sacrifice lower part of the amygdala to enter into the temporal horn to take out hippocampus. So trans-amygdalar approach has come because you showed us why how dangerous it is to make an incision behind the Lyman in the inferior limiting sulcus. Lovely, learned a lot, and we'll be listening to your talks more in future. Okay, Abhida, lovely. Okay, congratulations.
Thank you, sir.
Thank you. So I have a question. Can I ask, Dr. Abhida?
Yes.
There is atrial lesion, like atrial meningioma or any other lesion in the atrium ventricle. That's a deep-seated lesion. A lot of approaches to treat or to deal with this lesion. We know because we try to avoid the eloquent cortex as well as the white matter fiber. Could you please tell us regarding the avoidance of the white matter tract to reach the atrium? How to avoid the
If you want to avoid white fibers completely, if you want to reach the atrium, then you have to go interhemispheric. If you go from the medial aspect and you enter the choroidal fissure from there, then you will avoid all kinds of fibers because the optic radiations will be lateral to the atria. There is another approach that is from below, that is from supracerebellar transtentorial. You can enter into the atrium from below. It is a little cumbersome, but that is another approach that will avoid the fibers, major fibers. Otherwise, the classical approach on the right side, which is considered to be safe, is through the parietal eminence and through the superior parietal lobule. So if you have to go from the transcortical avenue from the lateral side, then you will try to go to the superior parietal lobule and avoid the inferior parietal lobule or the region of the angular gyrus, because above that it is little safer as compared to below. But if you want to avoid all kinds of injury, you go from interhemispheric.
In case of posterior interhemispheric approach to deal with this atrial lesion, what has been described by the Professor Yassergin sir, but we have seen that in case of posterior interhemispheric approach to the atrium, we have to damage the cingulum, the part of the singular gyrus,
yes,
the isthmus, as well as the cingulum, to enter into the atrium. What do you feel regarding this issue?
Yes, some part of the cingulum may be, if you go straight callosal, if you straight make a callosal incision, you will avoid. But oftentimes the ventricle is so enlarged and the brain is quite tight. So while retracting, yes, the cingulum does damage. We have also done it, but we have not seen any major post-operative effects because of this. Maybe because the cingulum is quite a widespread tract and it has a lot of connections to the cortex, to the frontal, parietal, and the temporal cortex, and it is quite a thick bundle. So little damage to it. At least we have not seen any clinical consequence of it. We have also gone through the cingulum in quite a few cases, but it has not caused too much clinical consequence.
We have Professor Shafiqul Islam sir. He is our mentor and main man behind the CNW group Bangladesh. Professor Shafiqul Islam sir, would you please put your comment? Shafiqul Islam sir, are you here? Possibly he's not here.
I believe he was in. I'll check.
Oh, yes, sir is here.
Yeah.
Yes, sir.
Yeah, thank you, Professor Abhidasha, for the wonderful talk. Hello.
Yes.
Yes, sir. We can hear.
I had an opportunity to work with him in KEM Hospital. I think it is around 2010.
Yes.
That was a nice opportunity also, and I learned a lot from you in this difficult.
I cannot hear you clearly.
Yeah. The connection is not too good.
My device is
Yeah,
not
now it's
working
better. It's
properly.
better. Yeah.
That's better.
Yeah, just I wanted to thank you for your wonderful lecture.
Thank you, sir. Thank you very much.
Congratulations. And I had an opportunity to visit KEM in 2010 and Professor Atul Goyal sir for a couple of weeks.
Yes.
I also worked with him. So thanks again for a brilliant talk. Thank you.
Okay, more comments, questions?
I have seen a few questions in the Q&A.
Okay.
And in chat box also. Somebody, just see, somebody has question.
Can I ask one question?
Yeah,
Hello?
of course.
Natasha?
Hey, Sue, how you doing?
Go ahead.
Pretty good. Can I ask one question to Natasha?
Yes.
May I know about the visceral disturbance in the CPNS adenoma? Good classification, grade 3 or 4. Sometimes we present at the visceral disturbances in CPNS adenoma.
So that's not because of any white fiber that is getting involved. There is another theory for that there is some protein that is secreted which causes some kind of hydrocephalus and secondary visual deterioration. So it's not related to any visual any white fiber pathway.
Yes, thank you so much.
Thank you very much. The question was how you have prepared your brain for white fiber dissection. Can you tell us?
So we fix it in
briefly?
formalin first, and then we freeze it. And it's the classical Klingler method that we put it first, fix it in formalin for some time, then we freeze it for a month or so, and then we thaw it, and then we start the dissection. You have to do it a few times to perfect it. I mean, this is something you just learn when you start doing it on your own.
Thank you. We can see here Professor Moinul Haq Sarkar. He is our professor, our mentor in Bangladesh. Professor Moinul Haq Sarkar, sir, would you please put your comments? Can you hear us, sir?
We're not very lucky today.
Possibly, we cannot understand. We have got, as I said, Professor Mohammad Hussain. Would you please put your comment? He is working with white fiber dissection tactography also. Would you please put your comment? Mohammad
Hello. Thank you, Dr. Suman and presenter. This was a very nice presentations. Basically, I am on my home, so I am in the car. So I am using tactography for the last 1.5 years, especially whenever it is in the eloquent area. And if we know the white fiber, especially origin and insertion, then it will help us. So the comment that you said in your presentation that tactography, you must know the anatomy first. So I think if we know the anatomy and origin insertion of the fiber tract, then tactography will help. And basically the surgeon must know how to draw and how to use the tactography. Otherwise, it will not have no value to dissect the white fiber and do surgery like this. Thank you very much.
Thank you. Yes, I agree completely. As I said, that you have to go yourself and see it. Your radiologist is not going to give you any decent information. They will just give you all the tracks and that's it.
This case
you have to go and do it yourself.
Yeah, this is the surgeons who have to go to the radiology room, CT MRI room, and then surgeon must have know where the what to do and what not to do. Then it will help to resect the tumor, especially in the eloquent area.
Yes.
Hi, John.
Yes. Okay. Any more comments, questions from the panelists? I believe Abdallah Zaiden had a question. Are you still there, Abdallah? You may have stepped away. Our streak continues, Mohammed.
No, I'm still here. I'm
Oh,
still
there he
here,
is.
but
yes, we're waiting for you.
I wrote my question. Professor Abida Shah is a real successor for Professor Atul Gul. Both are really stars of the Indian neurosurgery, and I'm really enjoying your anatomy sessions. I've attended before the cavernous sinus and today the white matter. It's really something amazing. But may I have a request, Dr. Abida? Is that when you are giving us these, well, for me, it's a little bit, I've never read about these white matters before, white matter tracts before. I mean, we knew some of them by old methods and old schools. But what we know now is there are plenty of arcuate and complicated tracts, which we really need to know the function of each of them. So I'd like to see this lecture again, but while you are showing us the tract, to tell us this tract is carrying so and so and so functions. I think that will make it more functional, more applied in our brains to know how to get to a tumor or to lesion in that area in a more practical way. I think this is the modern era now of medical students. My daughter and my son are in the medical school now. One of them is finishing now; she's in the 5th year, and my son is in the 2nd year. They are starting to give anatomy with clinical aspects, with physiology, with biochemistry of the same organ or function or disease. I mean, I think this will be more. how to say it, applicable to our area of work. What do you
Yes.
think about that?
Yes, yes, definitely. You have
I
to
mean,
first,
it's clear you did very hard, very nice, very beautiful job. Nobody can criticize that. But what we want from you is to give us the application for it. I mean, you will be
so what,
really doing the maximum
basically,
for that.
basically when you are a surgeon, for you anatomy is the most important thing. It is your Bible. Without your anatomy, you are nothing. So
But
what you do, yes, yes,
functional
yes.
anatomy.
Yes. So first you learn the basic core anatomy, and then you go ahead and read the function of each of them. So as you said, we can discuss at some later date again with the function of each tract. Of course, anatomy is just will give you your surgical knowledge, but you have to, of course, apply functional to it. Otherwise it doesn't make sense. So of
Sure.
course you have to do both surgical, anatomical and functional. And the way you are describing, this is a better way, like your daughter and son. It's a much better way to study medical science rather than just doing some basic subjects first and then going into the clinical aspects later. This is the modern way, and this is the better way that you correlate everything together and learn. I agree
Yes.
with.
Thank you. Thank you very much.
Okay, more comments, questions from anybody?
Yeah. Any question or query from the member of CNW Bangladesh? Any question or query?
Yeah,
You can
Assalamu
unmute
alaikum.
yourself. Yeah, Shahnawaz Biswas. Go ahead, please.
Sir, can I ask a question to Abida Shah, ma'am?
Yes.
Ma'am, sometimes in thalamic as well, if we have to approach through the transcortical route, so what are the fibers we should be concerning about, and how can we predict that there will be motor deficit in case of that patient?
See, thalamic tumors is better approach transcallosally through the ventricle because that is where it is projecting. If you're going to come from anywhere more laterally, you're going to damage the internal capsule or you will damage the thalamic radiation. If you come from superiorly, where it is located, you will be in the region of the precentral gyrus, again, which is a motor area. You're going to cause damage there. So, a thalamic lesion, whether you come from anterior or whether you come from posterior, or maybe you come from the temporal horn if it is projected downwards, or if it is projecting in the pulvinar, then you come from supracerebellar avenue. So basically for a thalamic tumor, you come from a cistern or you come from the ventricle. Avoid a transcortical approach. In general, you do not go. Either you come from the anterior interhemispheric or make a small incision in the posterior, just in front of the splenium in the posterior corpus callosum and enter the thalamus, or you enter from the temporal horn and open the choroidal fissure and go in, or you come supracerebellar and in the quadrigeminal cistern you approach the thalamus. So these are basically the central core is opening in these areas. This is where you want to enter the region from. This avoids injury to all the fibers.
Thank you, madam. Thank you.
So any other question from our CNW member or anybody in the panelists? Any question or query, please?
Okay, Mohammed, I guess we'll wrap it up. I would like to I'd like to thank Abby, but in in honor of her, Abby, participating, we've made a studio for her. Okay, and I've shown it to Abby. Here it is. Do you see this? Okay.
Yeah.
Okay. There's only a couple people studios. Abby, Victor's one of them. Pablo Gonzalez from Spain is another. Ipe is another, and you're the next one. There you are. And Abby, I expect you to decorate your studio tastefully.
Okay. Thanks.
No, when you do webcasts, you don't have to do it for us, but when you do them in other parts of the world, just let us know and we'll put them in your studio.
Okay.
It's not a requirement, but it's an option. And what's next week, Abby? What's the topic, Abby?
We are doing limbic system, I think, next week.
Okay, very good.
Yeah, limbic system and temporal approaches, I think.
Okay, very good. Okay, then. Thanks to everybody, and we'll see you next week.
Thanks, John.
Bye
Thanks,
bye.
Mohammed.